Dear students, dear supervisors, please let me introduce my 9th-month progress of my 2 ongoing projects. My PhD topic is the surgery of the pelvic organ prolapse and female stress urinary incontinence. My name is Júlia. I am a PhD student and a resident doctor at the Urology clinic. My mission is to reduce the complications of the pelvic organ prolapse surgical treatments, and my vision is to formulate recommendations for surgical treatments in terms of the indication, contraindication, and patient selection. I have 2 ongoing projects. The first one is investigating the safety and efficacy of the female pelvic organ prolapse surgeries with versus without vaginal implants. 1 in 2 women over the age of 50 have a certain extent of pelvic organ prolapse. 11% of the women undergo a surgery for POP by the age of 80, and in many cases an implant surgery is required to treat the disease. With implants we can achieve an excellent anatomical correction. However, there are some complications, and the increasing number of the complications why the FDA has issued several warnings, and in several countries, including the USA, completely banned the use of vaginal implants. But now there are no clear recommendations and no updated guideline. So we would like to compare the safety and efficacy of female pelvic organ prolapse surgeries with versus without vaginal implants. The question is whether there are any differences regarding the complications and the efficacy between the patients who undergo a POP surgery with or without implants. The population was females who undergo POP surgeries with a vaginal approach. The intervention was the surgeries with implants compared to the surgeries without implants. The main outcome was the complications, and the other was efficacy, which we mean anatomical success. We used the population and the intervention and the search key, and finally 77 articles were eligible. We got all data and we categorized it. There are some summarization of the complication and include the reoperation rates, the reoperation due to complication, and the total reoperation rates, which include also the reoperation due to recurrence. The efficacy parameters like anatomical success, POP stage, and POP coup points, and the functional postoperative complication and the non-functional complications. We built a multivariate model analysis to get better results. And in this first figure, you see that the multivariate analysis of the non-functional complications. And I would like to highlight 2 complications, erosion and bleeding, which connected to each other because bleeding means vaginal bleeding. But you can see it was more common in the implant group. However, buttock pain was more common at the native tissue group. And you see erosion was the most relevant complication. The next figure is the multivariate analysis for the functional complications. I would like to highlight the de novo stress urinary incontinence, which was more common in the implant group, but it comes from the nature of the operation because the prolapse put passive pressure to the urethra, and after when we solve the problem, the hidden de novo stress urinary incontinence come. And in this picture you can see the efficacy parameters. It was also a multivariate analysis. The anatomical success was significantly better with implant. However, it was a short follow-up time. The median follow-up was 1 year. But we think that during the time, the anatomical success is more better with implants. Okay, the other outcome was the reoperation due to complication, which was higher in the implant group. and the reoperation due to recurrence was higher in the native tissue group. It was an extensive analysis of the complication with a high-quality studies, mostly RCTs, and on a large population. We have some limitations like the rare events and the heterogeneity, which comes from the different vaginal compartments and the different implant types. The conclusion is pelvic organ prolapse surgeries with vaginal implants is more effective procedures with an acceptable complication rate, and the leading complication is erosion. We have some implication for the daily practice. We need to revise the use of vaginal implants in the pelvic organ prolapse surgeries, and we need to modify the guideline to the daily practice, and we should select the best target population where we can recommend these surgeries. The implication for research is we need to design more RCTs, and we need to analyze the prognostic factors which predispose to complications. We finished the manuscript and we are waiting for the authenticity check, and as soon as possible, if we come back, we publish. We would like to submit to the European Urology, which is the D1 journal. The second project is investigating the risk factors associated with erosive complications after female pelvic organ prolapse surgeries. The background is similar to the first project, but based on the results of the first project, erosion is the leading complication. And this is why we would like to identify the causes and the prognostic factors predisposing to mesh erosion after vaginal pelvic organ prolapse surgeries. The question is, which is the subpopulation of the patients who shouldn't undergo pelvic organ prolapse surgeries with vaginal implants? The population is females who undergo pelvic organ prolapse surgeries with these implants. The factors are the risk factors like age, menopausal status, obesity, smoking, sexual activity, and the outcome is erosion. The clinical implication is decrease the erosive complication rate and increase the safety of these surgeries. We have two hypotheses. The first one is there are specific risk factors which associate the erosive complications, and the second one is to identify the potential factors. With this identification, we can reduce the occurrence of erosion after the surgeries. We use the population and the outcome of the search key. We have 11,627 articles after the duplication removal, and we are currently working on the title and abstract selection. And we would like to finish in this week. This is the summarization of the two current projects, and I would like to close my presentation with a quote from Michael Jordan: "Never say never, because limits like fears just often illusions." Thank you.
Very nice presentation. Regarding your topic, are there any patients you do not suggest to place these implants, or is it usable for every patient? What's your opinion?
Based on the experience of our clinic, we do not recommend the implant surgeries for the very young women, very young sexually active women, or a woman who had vaginal atrophy or some vaginal wall thickness. But it's just our experience, and this is why we perform this meta-analysis, because we would like to involve more patients, and we would like to involve more clinics with a different surgical practice, with a different population.
So first of all, congratulations to the great work. And in your first topic, you mentioned that you need to change the guidelines. Do you have any suggestions for that?
Actually, we have 4 guidelines in the urogynecology field, which contain some recommendations to these surgeries. But the guidelines are very different, and for example, opposite to each other, and we would like to design better recommendations to fit the patients and to fit the results of the researches.
Okay, thank you.
One thing that it was banned in the United States, but morcellation of fibroids was also banned for a period of time. So it could be a changing thing if a strong review or meta-analysis comes out confirming these results.
You mentioned the 4 guidelines. Is it from Europe or is it from Hungary with regard with POP?
Is it from Europe? There are British guideline, the American guideline, and in Europe we have also a guideline, but
Why not change the Hungarian guideline then? If you have this meta-analysis and just because you as a physician you cannot use these operations if you have some contraindications for that in the leading guidelines, including the US guidelines, you know. But if you implement Hungarian guidelines with your results,
maybe
that
we
might
can
be a direction.
maybe we can modify.
Okay.